Hi, my name is Lisa Kallenbach, and I am a physician in Janssen Pharmaceutical Company. I'm going to talk to you today about chronic myelogenous leukemia. We're going to discuss the epidemiology of chronic myelogenous leukemia, also known as CML, the pathophysiology of the disease, the signs and symptoms of CML, and how to diagnose it. And then we're going to touch on the treatment of CML, including the use of imatinib or Gleevec, its mechanism of action, side effects, and the long-term follow-up of patients with CML. I'll also discuss other new medications that have come along for use in Rwanda as well. So we're going to start with some pre-lecture questions. Question number 1, what type of disorder is CML? A, solid tumor, B, myeloproliferative disorder, C, leukemia, or D, both answers B and C. Question 2, what is the main therapy used long-term to treat CML? A, hydroxyurea, B, prednisone, C, imatinib, D, Rituxan. And question 3, what is the translocation that is most often associated with CML? A, the Philadelphia chromosome, translocation 922, B, C-MYC translocation, T814, or C, the BCL2 mutation, which is translocation 1418. I hope that you'll be able to describe the basic epidemiology of CML and understand the pathophysiology, recognize the signs and symptoms of CML and how to diagnose it, and describe the treatment of CML, including the use of imatinib and its mechanism of action and side effects to look for. So let's get started with the basic epidemiology of CML. So there's no known association with race or ethnic group with this disorder. It does account for 15 to 20% of all leukemias in adults. There's an increasing incidence with age, and the median age at diagnosis is about 65 years. And it can be seen in all age groups. So it doesn't have peaks at certain age groups. The only known risk factor is ionizing radiation. So let's talk about the pathophysiology. So CML is a myeloproliferative disorder. It's a clonal, uncontrolled production of transformed primitive stem cells, hematopoietic stem cells, predominantly neutrophils, but also basophils and eosinophils. Because it's clonal, it is also, that's what makes it a cancer, but it is also a leukemia because it's a cancer of the blood. What causes CML? So CML is caused by a translocation between chromosomes 9 and 22, which is also called the Philadelphia chromosome. So a small piece from 9 goes to 22, and a piece from 22 goes to chromosome 9. That forms a unique protein product called BCR-ABL, and that acts as a kinase which drives the stem cell proliferation. It takes away the off switch. So here's a picture of basically the piece of 22 going to chromosome 9 on the right, and the piece of 9 going to 22 on the right part of the right side. So a piece of chromosome 9 breaks off, piece of chromosome 22 breaks off, they switch places, and that leads to this BCR-ABL protein formation. So let's discuss the signs and symptoms and when to refer to Butaro for evaluation. So CML is usually diagnosed in the chronic or stable phase, which we're going to talk about later. About 20 to almost half of patients will have no symptoms, and they're diagnosed simply on a screening complete blood count. So you'll see a leukocytosis or very high white count, but they will be otherwise asymptomatic. Some non-specific symptoms that patients might complain of include fatigue, weight loss, malaise, splenomegaly or abdominal distension. So they would complain of abdominal distension and you would note splenomegaly on exam. There are different phases of CML. So the chronic phase is the most, the chronic phase is the most common, which is what we talked about in the last slide. The accelerated phase presents with a more difficult to control leukocytosis and decreased differentiation of the neutrophils. So you start to see a little bit more blasts. And then blast crisis resembles an acute leukemia. And there's elevated myeloid or lymphoid blasts in the bone marrow and peripheral blood. And it has to be over 20% to meet criteria for leukemia. You'll also note worsening anemia and thrombocytopenia as there's less space in the bone marrow for those cell lines to grow as there's expansion of these leukemic cells. The differential diagnosis includes a leukemoid reaction. So there you'll see an accumulation of non-malignant granulocytes in response to either an infection or some other inflammatory stimulus. So you'll see the same increase in the variety of the neutrophil cell line, but they won't look dysplastic, they'll look normal, just increased. Other myeloproliferative neoplasms include polycythemia vera, essential thrombocythemia, and chronic myelomonocytic leukemia, or CMML. In those situations, you would probably see other things like polycythemia vera. You would see a very high hemoglobin level, typically. In essential thrombocythemia, you see a very high platelet count. And in CMML, you might see a very low platelet count or note dysfunctional platelets with patients complaining of those symptoms of bleeding and things. Other leukemias that are on the differential include acute myeloid leukemia, Philadelphia chromosome positive acute lymphoblastic leukemia, or lymphoblastic lymphoma. So rarely patients will present with other problems due to an incredibly high white blood cell count and leukostasis. So when the white count gets very, very high, the blood is not flowing as well. So they may complain of dyspnea or priapism or visual disturbances or bone pain. And that's more often seen with more accelerated or blast crisis CML. So the diagnostic workup includes blood work, where you'll likely see a very high white blood cell count and possibly high platelets. On a peripheral smear, you're going to see all stages of myeloid development. On pathology, a bone marrow biopsy is required, and that is sent for histology, cytogenetics, FISH testing, and molecular analysis to detect that protein product, that BCR-ABL product. In the cytogenetics, you will see the chromosome 922 translocation and the BCR-ABL protein is detected on PCR testing in the upper blood. And that translocation is seen in over 97% of patients with CML, but there are cases of atypical CML that are not associated with this translocation. But that's much, obviously, more rare. So let's talk about the treatment of CML, including the use of imatinib, and how that drug works and its side effects, and how to follow up patients with CML. So hydroxyurea is what we use immediately to lower the white blood cell count, and was a mainstay of treatment until other treatments came along. Allogeneic stem cell transplant was one potentially curative therapy, and Gleevec or imatinib has really replaced that as the mainstay of therapy now. If the patient is in the chronic phase, but untreated, so without therapy, last crisis or transformation to acute leukemia occurs in approximately 2 to 6 years. The leukemic phase of CML requires standard leukemic therapy followed by bone marrow transplant, and cure is rare. But often, because most people present in the chronic phase, we are able to treat this as a chronic disease in most cases. So when you urgently have a patient with a very elevated white count, we urgently have to bring that down. And we use hydroxyurea to do this. And typically we use doses up to 2 grams once a day orally. And we continue that until the white blood cell count is under 50,000. And then you can transition to Gleevec or imatinib. And the important thing here is to monitor for anemia and other cytopenias, because hydroxyurea will drop many of the blood counts. Gleevec or imatinib is to be used in patients who have confirmed BCR-ABL fusion gene product noted on PCR testing. And the dosing of Gleevec is 400 milligrams once a day to start, and it can be titrated based on the response with a maximum dose of 800 milligrams a day. We also now have dasatinib available if there's Gleevec failure in Rwanda. So we'll go through some of the response criteria that we expect in this disease. And if you don't meet those criteria, but have been taking your medication compliantly, then we would switch to dasatinib. So Gleevec or imatinib was the first, quote, designer drug approved in the United States in 2001. Because it's designer in that it targeted exactly the pathophysiological problem and corrected it. So it inhibits the BCR-ABL tyrosine kinase because it competitively binds at the ATP binding site, and then it normalizes the cells can then mature. The cell lines can then mature the myeloid cell line. So the first thing you'll see is that the hematologic, the blood work, corrects first. So we start imatinib at 400 milligrams per day. About 92% of patients will achieve a major cytogenetic response, meaning when we test for that BCR-ABL protein, gene protein, we can't see it anymore. The progression-free survival is 84%. Yearly progression is about 4%, and only 2% relapse to the accelerated or blast phase. The advantages of imatinib is that it's oral and it can provide very long-term disease control, and it's available worldwide. The disadvantages are that you do have to stay on lifelong therapy in most cases, that it's difficult to remain compliant over time, and there is development of resistance over time, and there are side effects, as with any medication. So the most common side effects are hematologic toxicity with a low white blood cell count or low platelet count, and that occurs in about 15% of cases. Elevated liver function tests, edema, congestive heart failure, rash, alterations in bone metabolism, and autoimmune issues, which are extremely rare. To measure a response to imatinib therapy or dasatinib therapy, but if we're starting with imatinib therapy, we first want to see a hematologic response. So again, this is the normalization of the white blood cell count. We wouldn't see any more immature myeloid cells in the peripheral blood, and less than 5% basophils. The platelet count should also normalize, and the spleen should no longer be palpable on physical exam. Then we look for a cytogenetic response. And this requires a bone marrow biopsy, but it's assessed by chromosome banding of the marrow metaphases with at least 20 metaphases analyzed. And then we want a molecular response. In the peripheral blood, we can look at the BCR-ABL transcripts on PCR testing. And it's expressed as a percentage on a log scale. And the goal is to have less than 0.1 transcripts present at 1 year. So after 1 year of imatinib therapy, we don't want to see we want to see less than 0.1% of transcripts. So some things about Kallenbach and the responses. So that would indicate failure. So if there's no hematologic response at 3 months, that's a sign that Kallenbach may not be working. And the first thing you would do is increase the dose of Kallenbach from 400 to 600 milligrams a day. The other thing you might see is an incomplete hematologic response at 6 months, meaning things didn't completely normalize. You saw some response, but not complete. You could also see less than a partial cytogenetic response at 12 months. You could have less than a complete cytogenetic response at 18 months, or loss of a hematologic or cytogenetic response at any time. So you had a hematologic response and then you lost it, or you had no evidence of the translocation cytogenetics, but then you see it again. So not only can you increase the dose of imatinib, but other options in case patients can't really tolerate those increased doses is now you could change to dasatinib or nilotinib, which is, they're both second generation tyrosine kinase inhibitors in the same class as imatinib, but they're newer, and I'll discuss dasatinib in a little bit more detail in a minute. The other thing in the United States is that allogeneic stem cell transplant could potentially provide a cure if none of these medications are working. And then the other issue with these drugs is that most people will require them indefinitely, and there's always the risk of non-compliance or just stopping because people will get tired of taking medication. So you do have to encourage people to stay on this lifelong almost, though, in most cases. So just to talk about dasatinib briefly, this is a second generation tyrosine kinase inhibitor. It was approved in 2006. The estimated 5-year overall survival on this drug is 91% versus 90% for imatinib. It does lead to faster responses compared to imatinib, so that hematologic response, and then higher rates of major molecular response and cytogenetic response. We don't know if it has any effect on overall survival, but it does get you to the points that you want to reach faster. It has some similar but a few different side effects. It does cause cytopenias, as does imatinib. This causes more pleural pericardial effusions, and you can often stop the drug and try and restart a lower dose if that is a possibility. Pulmonary arterial hypertension, edema, which is similar to imatinib, QT prolongation, bleeding with a platelet-like, an aspirin-like effect, and diarrhea. Both are teratogenic, imatinib and dasatinib, but dasatinib is available for imatinib failures currently per protocol in Butaro. And then this is just talking about the progression of therapies, like how we've gotten to where we are now. Basically, it started way back in the 1800s with arsenic and splenic irradiation, which were all palliative, and busulfan and hydrea. And then we started to move into more curative therapy with stem cell transplantation. And then now we're talking about long-term disease control, possibly cure, with imatinib and the second generation TKIs, dasatinib and nilotinib. So we've come a long way in treating CML and turning it into a chronic disease. So in summary, CML is a hematologic malignancy that results in very high white blood cell counts. It is readily treatable with imatinib, which is an oral medication that does not cure the disease, but significantly prolongs life, and in a few cases may cure. The characteristic features are splenomegaly, elevated white blood cell count, and positive BCR-ABL testing, which tests the presence of the Philadelphia chromosome. Here are a few references for further reading. One is older, the first one is a little bit older, but has a nice review and update and can illustrate how the therapy started to change so much in the early 2000s. And then the second one really talks about adherence to oral tyrosine kinase inhibitor therapies, which is the main problem, I would say, in this disease, is that people have a hard time taking their medicine. So I would say the most common cause of failure is non-compliance. And then this newer discussion of how much tyrosine kinase and how long. So there are studies going on now to see if it's possible to stop therapy after X number of years and a certain depth of response. So that's just for your information. Thank you for your time today. And if there are additional questions, I know people are available to answer them live for you. Okay, we're going to review the post-lecture questions. Number 1, what type of disorder is CML? A, solid tumor. B, myeloproliferative disorder. C, leukemia. Or D, BNC. And the answer here is D. It is both a myeloproliferative disorder as well as a leukemia. 2, what is the main therapy used long-term to treat CML in most cases? A, hydroxyurea, B, prednisone, C, imatinib, or D, Rituxan? And the answer here is imatinib. And we also discussed during the lecture some second-generation drugs such as dasatinib. Three, what is the translocation that's most often associated with CML? A, the Philadelphia chromosome, translocation 922. B, the c-MYC translocation, translocation 814. Or the BCL2 mutation, translocation 1418. And the answer here is the Philadelphia chromosome, which is translocation 922.